Unfortunately, it is very common to know someone who has cancer or has gone through cancer diagnosis and treatment. Cancer can and does target every body system. Likewise, cancer treatment can also come in many forms, the majority of which cause very serious side effects and leave patients in compromised immune and functional states. Exercise has been studied as an additional treatment to counteract the deleterious effects of traditional treatment, and these studies have shown incredible positive effects. As such, those exercise prescriptions should be applied to colorectal cancer patients. Of course, it is important that clinical trials be conducted to investigate the effects of exercise in this population. Throughout this presentation, we will explore the current epidemiological data concerning the disease, evidence from previous exercise trials in this population, and propose new directions for clinical research. To begin a discussion on the application of exercise as an additional treatment for colorectal cancer, it is important to understand why this is an issue. Here we can see how the incidence and mortality rates of colorectal cancer among different age groups have changed over the past few decades in the United States. In the higher two age brackets, 50 to 64 and 65 plus years of age, we see promising decreases in both incidence and mortality. However, in the youngest population segment, 0 to 49 years of age, incidence and mortality have been steadily climbing over the past 25 years. This increasing trend is frightening to see, especially in a young population, which is usually associated with overall good health and longevity. Here we can see the epidemiological data on both colon and rectal cancer mortality worldwide from 1989 to 2013 and predicted rates to the year 2035. In both cancer types, we see that the death rate is decreasing while the death count is increasing steadily. Just from looking at these graphs, the relationship between these two counts may not make sense. How can the death count increase while the death rate decreases? There are a few factors to keep in mind, including the amount of people diagnosed with colorectal cancer who unfortunately pass away years after their diagnosis. There are also improved treatment and detection techniques put in place as time goes on. Another specific point to make on the death rate is how it is calculated. Generally, death rates are calculated by taking the number of deaths due to exposure or disease and dividing it by the total population. So, death rate and the population are inversely proportional, meaning as population increases, the calculated death rate will decrease. Because of the effect of population on death rate, the important trend to see here is the increasing death count. As we will continue to see a rise in the number of deaths attributable to colorectal cancer in the near future, it is important that we determine the most effective form of treatment for these patients. As we determine which treatments are most effective, it is important to consider how exercise can be used as an additional treatment. Regardless of the type of cancer, numerous studies have shown the positive effects of exercise treatment on tumor size, functional ability, body composition, and disease-free years. Without a doubt, an exercise intervention would hopefully be applied to colorectal cancer patients. Fortunately, this has been done, and similar positive effects have been shown. First, it is important that an exercise intervention is feasible. Systematic reviews have found that various exercise interventions that utilize different intensities of aerobic exercise in different intervention environments, etc., produce adherence rates from 75 to 89%. In another study investigating the dose-response relationship between body composition and physical activity, investigators found that each 60-minute increase in aerobic activity per week produced a 2.7 centimeters squared decrease in visceral adipose tissue. Importantly, many interventions have been conducted comparing the effect of intensity of aerobic activity on body composition and cardiovascular fitness. Throughout these studies, those with the most effect implemented high-intensity interval training, typically on a stationary bike, at 85 to 95% of patients' age-predicted heart rate maximum. These studies were usually 8 to 12 weeks in duration and produced up to 35% increases in VO2 max, up to 1 kilogram decreases in fat mass, and increases in lean mass that mirrored the decrease in fat mass. Compared to high-intensity interval training, lower-intensity aerobic exercise at 65 to 75% of patients' age-predicted heart rate maximum produced no significant changes like those seen in high-intensity interventions. There's a dearth of trials and evidence that speak to the effect of strength training on body composition and disease status. Few studies have reported lower limb strength gains of 24.1 kilograms over a 6-week program, but no effect on upper limb strength. Clearly, various studies have shown beneficial effects of exercise as an additional treatment for colorectal cancer. However, it is important to determine whether these interventions serve patients well in the long run as it relates to disease recurrence. An important area to pay attention to when doing research in this population is an intervention's effect on long-term survival. In a systematic review published in March of 2020, reviewers investigated this very question. This is one of the only studies or reviews that have truly looked at this issue, and its results are not exactly conclusive. In this table here, we see the comparisons between hazard ratios among different studies that implemented an exercise intervention as adjuvant treatment for colorectal cancer patients. This analysis included 7 individual studies that use similar exercise treatments in control groups. 5 of these studies have hazard ratios that are near 1, meaning it is hard to discriminate definitively whether the new treatment or old treatment is favored. 2 studies, including the 2018 Marco and 2017 Markovina studies, are clearly in favor of the new exercise treatment. The question now becomes, when all of these hazard ratios are combined to give an overall hazard ratio, do the 2 studies with hazard ratios clearly less than 1 pull the overall ratio of all 7 studies down enough where if they weren't included, we would see a hazard ratio around 1? Essentially, do these 7 studies offer a total hazard ratio that will definitively say that the new treatment is favored over the old? Again, because there's a deficiency of research that has looked at the long-term effects of an exercise intervention, we cannot draw an effective conclusion about the long-term effects from studies conducted thus far. So now that we have seen evidence from previous studies, the important question now becomes, what's next? The majority of the evidence shared thus far is in favor of adopting or prescribing exercise to colorectal cancer patients, but there are still numerous gaps in scientific literature and knowledge that need to be addressed. Here, we see those gaps that persist in research in this area. Throughout the literature review process, these 4 areas were constant sources of questions that could not be answered by the published literature. For example, multimodal exercise interventions have received little attention. Similarly, there are many pilot trials that have not been amended or reapplied to the population as a randomized controlled trial. In the randomized controlled trials reviewed, many were limited by the amount of subjects enrolled and the design of the study itself. Alongside those limitations, a very small amount of studies have looked at the long-term effects of their intervention on disease recurrence. On top of that, implementing a behavioral intervention that supplements or runs alongside an exercise intervention has not been adequately explored or reported. Answering these questions and filling in the gaps is vital to providing effective and valuable treatment for these patients. In an effort to fill in those gaps, a plausible next step would be conducting another trial, specifically aimed at tackling those key questions. Because the bulk of the published literature in this area focuses on aerobic exercise interventions, I propose a randomized controlled trial that is comprised of 3 treatments: an aerobic group, an aerobic and anaerobic group, and a standard care group. This way, we can investigate the effects of exercise type on various objective measures. Throughout the trial, group behavioral counseling will be given to all treatment groups. This counseling will be modeled using constructs from self-determination theory and social cognitive theory. The aim in using theory-driven behavioral counseling is to promote lifestyle change in tandem with behavioral change conducive to positive physical activity practices. The study itself will take place over 6 years, ideally recruiting a large number of participants spread out over multiple waves of the trial. The intervention is front-loaded, where we offer an active intervention with exercise sessions and behavioral counseling in months 1 through 12. The exercise sessions will be tailored to each participant. In the aerobic group, participants will progress to 45 minutes of high-intensity interval exercise at 70 to 90% of their age-predicted heart rate maximum on a stationary bike. In the aerobic and anaerobic exercise group, participants will progress to walking, jogging, or cycling for 20 minutes at 65 to 75% of their age-predicted heart rate maximum. They will also participate in muscle strengthening exercises for the upper body, lower body, and core. The standard care group will not be given an exercise protocol to follow, besides what their primary care physician and oncologist recommend, or they will be encouraged to continue their current level of physical activity. In months 1 through 6, Each group will meet twice per week. In months 7 through 12, each group will meet once per week. Contacts will be equal among all of the groups. Follow-up testing is interspersed within the intervention component during months 6 and 12. Longitudinal follow-up assessments will take place at 18, 24, 30, 36, 48, 60, and 72 months. During these follow-up assessments and an initial baseline assessment, participants' body composition will be measured using dual X-ray absorptiometry. Cardiovascular fitness will be measured via VO2 max on a cycle ergometer. 1 repetition max strength testing using leg extension and chest press will also be conducted. Physical activity behavior will be measured using the Godin Leisure Time Exercise Questionnaire. An accelerometer will also capture physical activity for 1 week after a follow-up assessment to give objective data about physical activity behavior. Disease status will be evaluated from medical information gathered by a participant's oncologist. Finally, to measure the effectiveness of the theory-driven behavioral component of the intervention, participants will be given questionnaires to answer that relate to specific theory constructs like motivation, behavioral regulation, and self-efficacy. The questionnaires include the Psychological Need Satisfaction and Exercise Scale, the Behavioral Regulation and Exercise Questionnaire, and 2 exercise self-efficacy scales. A trial design like this is aimed at determining how an exercise and behavioral intervention affects body composition and long-term disease-free survival, areas that have been given scant attention in the literature so far. The overall goal of this proposed trial, and a good future direction for the entire field, is to utilize previous interventions to inform larger and longer interventions to provide more evidence of exercise and lifestyle behavior changes and how they relate to body composition and fitness changes. A further investigation into long-term disease-free survival after an intervention, like the one proposed, is also necessary. The knowledge base as it stands now is a good foundation on which to design and implement To conclude this